Thank you, Ricardo. Good morning, ladies and gentlemen. It's my pleasure being here and participating to one of interactive session at the ECR this year. It's just a pity we are in such a small room and there are so few people, but we'll try to deal with. So, as you know, it is an interactive session, so it means that I will work little and you will work hard. I have two requests. First, you have to use your brain in order to answer the right question, and then to use your fingers, but not to use your fingers to send emails to friends during the sessions, but to press the good digit and when I will ask you questions. So my cases will be divided in two different parts. The first part will concern the diffuse liver disease, and the second one, the focal liver lesions and their mimickers. So let's start with the diffuse liver disease. Here there are three different patients, A, B, C, with imaging modalities, MR, CT, no matter about that. So the first question I will ask you is, which of these examinations show findings of cirrhosis? Is it all three? Is it only A? Is it B? Is it C? Or none of them? You can start to vote, please. Okay, let's have the results. All three was the most common answer, followed by A and B. Well, unfortunately, I must say that you failed the first question because the right answer was C, and I will try to explain why. As you know, cirrhosis is a diffuse liver disease which is pathologically defined by micronodular regeneration surrounded by fibrotic tissue. And this is indeed a key finding we can see at pathology, but also on CT, and more clearly on ultrasound and MR, and especially on contrast-enhanced delayed sequences, as well as on T2 sequences. We can see here the small, high-pointance nodules surrounded by fibrotic tissue. So this is one of the key findings of cirrhosis on imaging. The second one deals with the morphologic changes of the liver. As you know, in most of the patients with the cirrhosis, we will see a decrease in the right liver as well as a decrease in the segment 4. Meanwhile, there is an increase in the left liver lobe and in the caudate. These findings are rather specific for cirrhosis and enable distinction with other diffuse liver disease. The third very important finding deals with the surface nodularity. As there are nodules within the liver, nodules appear also at the liver surface. They are easily detected on imaging modality, especially using ultrasound with a high-frequency probe. But you can see here, and this is our patient A, where we see the changes in the liver surface with multiple nodules, as well as the atrophy of the segment 4 and the hypertrophy of the caudate. And this is another example. So here in this patient, we had the imaging findings of cirrhosis. However, there are some other diffuse liver disease that can alter the liver and induce changes in the liver morphology. So this is my second question. Besides cirrhosis, what are the main mechanisms of morphologic changes of the liver? Here, several answers are possible. First, is it related to portal vein obstruction? I think you can start voting now. Second, can we see such changes with hepatic venous obstruction? Third, could it be related to biliary obstruction? Fourth, some arterial obstruction could or not induce changes in liver morphology, or none of them. Please vote if you have not done so already. So as I told you, several answers are possible for this question. Let's have the results, please. Very interesting. You have selected portal vein obstruction, hepatic venous obstruction, and biliary as the 3 most common causes, and you are right. Congratulations. We will see why. This is a patient who had had a previous cholecystectomy, and as you can see, he developed marked atrophy of the right liver. We still see the right portal vein. What happens? During surgery, there has been an inadvertent right hepatic duct ligation. So yes, biliary obstruction can cause atrophy and simultaneous contralateral hypertrophy. This is a patient who had a portal venous thrombosis, but only on the left portal branch. And this is the MR after the diagnosis. You can see here the increased arterial enhancement, which is the usual imaging findings, and the lack of enhancement on the portal venous phase here. But look at the MR 6 months after. The left liver has shrunk completely. So this is the second cause explaining liver atrophy and, consequently, contralateral hypertrophy if the injured liver comprise several segments. And this is an example of a patient with a Hilar cholangiocarcinoma, and this tumor was mostly located in the right liver, but extending the hilum. As you can see here on this contrast and hand CT, again, there is a marked atrophy of the right liver. What happens in this case? Indeed, biliary obstruction, because we deal with the bile duct tumors, but also, as you can see here, right portal vein obstruction. So you can see really pronounced or marked atrophy when you have the combination of bile duct obstruction and portal venous obstruction. And last, we also can see morphologic changes of the liver in patients with hepatic venous obstruction. This is a patient with the Budd-Chiari syndrome. You can see here imaging findings suggestive liver congestion, which is usual, as well as striking morphologic changes with a marked hypertrophy of the caudate. This marked hypertrophy of the caudate occurs in about 50 to 70% of the cases and is related to the different hepatic venous drainage compared to the normal liver. So now we are back to patient A and patient B. I told you that this patient didn't have cirrhosis. So what are their disease? Here in the left, now you can recognize, I think, with a marked hypertrophy of the caudate, a Budd-Chiari syndrome. And on the right, what do we see? We see findings of portal hypertension with a splenomegaly, with the varices here, and we do see morphologic changes of the liver. However, are they likely to correspond to cirrhosis? No, because we see indeed a hypertrophy of the caudate, but we do also depict a hypertrophy of the segment 4, which is very, very unlikely for cirrhosis. If we look at the vessels, and if we pay attention to them, we can see here the common bile duct surrounded by multiple tiny vessels, and we do not see the portal vein. So this patient had a cavernous transformation of the portal vein, and later on we will explain why such morphological changes can occur in this patient. If we biopsy patient B, the liver will be completely normal. So next question. This is a patient who had an MR examination, and this is a T1 weighted gradient echo MR with in and opposed phase imaging. And my question is, which diffuse deposit is within the liver? You can start to vote. Is it related to liver steatosis? Is it iron overload? Is it a combination with the association of liver steatosis and iron overload? Is it another diffuse deposition such as the amyloidosis, or none of them? Please start to vote. Okay, let's have a look at the answers. So, you are right. Excellent answer. Why? Here we have two different patients who had the same MR sequence in and opposed phase imaging. On the top, you can see here in-phase imaging, here opposed phase imaging, and a drop in signal intensity on opposed phase imaging. This is because the signal of the fatty proton has been subtracted to the water proton. So clearly this is related to liver steatosis, and this imaging is 100% specific of steatosis. On the contrary, this is our patient. In our patient, this is the reverse situation where we do see a drop in signal intensity on in-phase imaging. This has something to do with in-phase and opposed phase? No, and I will explain what, but this is related to iron overload due to the increase in the T2 value. You know that iron overload creates MR field heterogeneity, and this heterogeneity is highly sensitive, much more sensitive when using gradient echo sequences, as you see here. So we have two patients, a control patient here and a patient with a mild iron overload. And by performing gradient echo sequences with increasing TE value here, we don't see many changes in the liver signal intensity. But looking here at our patient, we do see a liver signal drops with increasing TE due to the liver heterogeneity caused by the iron overload. So our patient definitely had an iron overload, and this explains why MR is so sensitive to depict iron overload, and we can not only diagnose, but surely very well quantify. Sometimes steatosis and iron can be associated, and diagnosis of such combination here require multi-echo sequences with in-phased, opposed-phased, and with increasing T values. Now we are moving to the focal liver lesions. So, next question. We have here two patients, A and B. Both have large focal lesions. My question deals with the tumor localization. Are these tumors intra or extrahepatic? So, 1, both are intrahepatic. 2, both are extrahepatic. 3, A is intrahepatic and B extrahepatic. And answer 4, A is extrahepatic and B intrahepatic. Can we see the vote, please? So, tumor localization. Okay, let's see the results. Oh, it's difficult because both are intrahepatic, maybe is the first one, and C, A is intrahepatic and B is extrahepatic. Yes, this is this answer which is correct, and I will explain why. But before, I'd like to ask you exactly the same question with two other tumors, A and B. Are they all intrahepatically located? Are they both extrahepatic? Is A an intrahepatic tumor and B extrahepatic, or the reverse? Let's see our results. Can we see the votes, please, and the number of people connecting? Thank you. Let's see the answers now. Okay. So still, I would say many different opinions. Maybe you have favored A is intrahepatic and B is extrahepatic. Unfortunately, the right answer, and I will explain, both are extrahepatic. this is a very difficult topic, and we often face this difficult situation, whether a tumor is intrahepatic or extrahepatic. And one rule is, larger the tumor, more difficult the problem. Let me give you some tips and tricks. First of all, try to look and to assess the tumor center. Here, in this case, this is one of the examples I just showed you. If you figure out that the center is here, the center is definitely outside the liver. So this is a tumor which has been developed outside the liver and which invades the liver. Another thing to look at is to look at the interface and the angle between the tumor and the liver. And this was also one of our cases. Here, we don't see the liver parenchyma going on both parts of the tumor, and we do see the compression by this tumor of the liver parenchyma. So again, this is a finding of extrahepatic tumor. Another very important issue is to look at the vessels and the vascular landmarks, and I would like to draw your attention to two very important vessels for that, the inferior vena cava and the portal branches, and I will explain to you why. And last, look not only at the liver, but also at the surrounding organs, and specifically in the right liver, where is the kidney? Is the kidney displaced? What about the adrenal? We go back to this lesion, which was extrahepatic. As you can see here on this contrast-enhanced CT, arterial phase and portal venous phase, this is the orientation of the left branch of the portal vein. Do you think that the left branch of the portal vein is in a normal situation? No. Usually the left branch should be like this. So if you have a tumor which grows from the posterior part extrahepatically, it will move anteriorly, clockwise, the liver, as you can see here. Another very important point is to look at the inferior vena cava. Do you think that the IVC is normally located here? No, it should be exactly at the same level as the aorta. So it is another finding to suggest that this tumor is not intrahepatic, but retroperitoneal. And last, this is easily seen on coronal or sagittal views. We can see here displacement of the right kidney. Do we think that this tumor is developed from the kidney? No, we don't see that. We see compression of the kidney. So this tumor very likely could come from the adrenal. And here, the specific scintigraphy allowed us to make the diagnosis of a cystic pheochromocytoma. So a very important and difficult topic. Let's see another case, again, which deals with tumor location. Same patients with a CT here and MR here. We do see some abnormality here in the segment 4 and 5 of the liver, here and here, next to the gallbladder. This tumor or pseudotumor is hyperintense on a fat-suppressed T2 exam and also well seen on a single-shot T2 weighted sequence. So, where does it come from? Again, here you've got the images. Is it an intrahepatic tumor? You can start to vote as soon as you have read all the questions. And is it extending to the gallbladder, or, on the opposite, is it extrahepatic and extending to the liver? Does it originate from the gallbladder, or none of them? Okay, let's have a look. Good, good. Even if some other people have chosen another answer, you are right. This comes from the gallbladder. How can we be sure of that? By doing sometimes a very simple but very useful examination, which is ultrasound. Here, it is difficult to assess whether the lesion is intrahepatic or not, But if you scan perpendicular to the lesion here, you can see the bright interface between the gallbladder and the liver. So definitely, this tumor or pseudotumor doesn't arise from the liver. And also, we can see here the close relationship with the gallbladder here. And it appears not as a cystic lesions, but heterogeneous with some bright spot inside, but is very well delineated and not really likely to correspond to gallbladder carcinoma. If we remember that this lesion was hyperintense on T2, then the diagnosis is easy. It is a gallbladder adenomyomatosis, which is a benign condition that does not require cholecystectomy. Okay, now we still deal with the lesions, but we are now within the liver, and I won't bother anymore to ask you whether the lesion is intrahepatic or extrahepatic. We have two different patients, both MR examination. These are in-phased and opposed-phased T1 gradient echo sequences, and of course now you very well identify the presence of fat with a drop in signal intensity here in A, located in the posterior part of the segment 4, and here in the right posterior segment. So you would agree with me that both lesions are fatty. But are these fatty lesions tumors or focal fatty steatosis? This is another pitfall which is very, very common in liver imaging. So I ask you whether these two lesions are fatty tumors. This is answer 1. Whether both are focal steatosis. This is number 2. A is a tumor and B is a steatosis, or the reversed. A is a steatosis and B is a tumor. Can I see the results, please? A is the steatosis, B is the tumor. You are right. Excellent. And now, because it is a very important and common topic, I would like to highlight a little bit the explanation of focal fatty sparing and or focal steatosis. They do not arrive randomly. You will see focal fatty sparing or focal steatosis in a very specific locations within the liver, mainly in the posterior part of the segment 4, and this was the case I just showed you, but also in the caudate or in the posterior part of the left liver lobe, as well as on both sides of the gallbladder. The reason is why. Explanation is provided by the portal vein and its branches. This is a CT reconstruction of the portal vein and its tributaries. Here the superior mesenteric vein, here the splenic vein. We are not really interested in the large veins. We will focus our interest in the small veins that usually drain directly in the portal vein. You should ask me why. Because this vein, which is called right gastric vein, has not the same component as this one, which is the posterior duodenopancreatic vein. This one does not contain insulin. This one has a high content in insulin. Usually, when both veins drain in the portal vein, the blood will be mixed and there won't be any heterogeneity within the liver. But, unfortunately, there are many variants of this venous drainage. Let me take an example. In this case, the right gastric vein drains directly in the liver, and this is quite common. So, some portion of liver will be supplied by insulin-poor blood, and therefore there will be very few fat within the liver, because you know that a high content of insulin within the liver gives always steatosis and the reversed. Okay. So if the patient has liver steatosis, and if this vein drains directly within the liver, it means that there will be here a focal fatty sparing. On the contrary, we are looking now at the second vein, the posterior duodeno-pancreatic vein. Again, this one may have abnormal variants and may drain directly in the liver, usually in the same location, as I said before. What will happen here? The blood, which will supply this portion of the liver, will be insulin-rich, and this will explain the focal steatosis. Now, let me show you, because maybe you don't believe me, why this is true. This is a patient who has been referred in our institution for suspicion of a liver tumor. If you look at the ultrasound, you can see that the liver is diffusely hyperechoic, highly suggestive of liver steatosis. Yet, segment 4, or most of the segment 4, is enlarged and hypoechoic. And this is well demonstrated again on MR, in phased or post-phased imaging, showing a drop in signal intensity here, indicating liver steatosis, and no fat here. Okay. Now if we move to the contrast-enhanced MR sequences, what do we see? And we have always to pay attention to these very small vessels. We see a vessel in a situation we usually do not see vessel. We see a small vessel here entering directly the segment 4. You know the liver vessel anatomy. This is not possible except in patients with abnormal variant of the portal veins. And we can be sure that this vessel is a vein because it enhances on the portal venous phase. We also performed ultrasound and Doppler ultrasound showing that this vessel has a spectrum which is highly compatible with the portal veins or its tributaries. And again, this abnormal hypoechogenicity was really centered by the vessel. So this is an example demonstrating focal fatty sparing related to abnormal venous, portal venous supply. And this is much, much more common than the focal steatosis. Let's go back to our patient, patient A, where you have very nicely make the diagnosis of focal steatosis, and you were right. Not only because the location, but also because we were fortunate in this patient to have a contrast-enhanced CT exam. Again, this is hypoattenuating, but much more interestingly, we could see here a small vessel entering the posterior part of the segment 4, but this time the vessel was not an aberrant right gastric vein, but comes from the pancreas with the insulin-rich portal blood. And this is another example. Even in patients with portal vein thrombosis, we can see very unusual and funny things. This patient had a portal vein thrombosis. On CT, there was an uneven focal fatty deposition, which predominates in the segment 4, as you can see here. And looking again at the contrast-enhanced sequences, we could see a vessel in an unusual location here, entering directly the segment 4. But it is difficult here, because this patient had a portal vein thrombosis, to only on these slices to assess where this vessel comes from. So we perform CT reformation here, and as you can see, again, this vessel is here. It enhances on portal venous phase, so it is clearly a vein which belongs to the portal vein, and we could be completely sure that due to its orientation, This vein was a vein of the portal cavernoma coming from the pancreas. So this is the explanation, this time, of a focal fatty steatosis, again related to an abnormal venous drainage of a pancreatico-duodenal vein. So in summary, in this case, which could appear rather complicated, they are not. My first message is focal fatty steatosis or focal fatty sparing arise in specific locations. Second, they are related most of the time to portal venous anomalies, and the rationale is the content of insulin within the vessels that explain sparing or focal steatosis. Let's move to another case. This is a 42-year-old woman which was asymptomatic, and in whom we fortuitously discovered multiple tiny hyperechoic lesions on ultrasound. She has had a CT scan which demonstrated multiple tiny hypoattenuating lesions here, scatterly diffused in the liver with no particular enhancement on contrast-enhanced sequences. So my question is here, in this case, what is the most likely diagnosis? Do you think that these lesions are likely to be liver metastasis, answer 1, or biliary hematomas, answer number 2, or liver hemangiomas, number 3, or steatotic hepatocellular adenomas, or last, pseudotumoral steatosis? Can we see the vote, please? Okay, let's see the result. So again, many different answers. Indeed, I agree that only the CT makes things very difficult, because there is probably one exam you would like to see. And I'm not ready to give you the answer to this question. I will ask you another question on the same case. Which MR sequence would be most helpful? In an opposed phase T1 weighted sequences, fat-suppressed T1, T2 weighted sequence, dynamic contrast-enhanced T1 weighted, or diffusion weighted sequence. And I will give you the answers of the two questions now, because indeed the first one is related to the second one. Okay. Very good. Can we see the answers to the first question? In an opposed phased image. Okay. But your most favorite... no, there is something... Okay. So you miss the... Yeah. So the answer to the first one is pseudotumoral steatosis. And even if you have not made the good diagnosis, you were right in the second question, because indeed, to make this diagnosis in an opposed phased, MR sequences are needed. So why this diagnosis? Pseudotumoral steatosis is a rare condition with no specific cause, and which might be sometimes difficult to diagnose on a CT. And indeed, you are right, we had to perform a MR examination, and MR is very demonstrative, again, by showing drop in signal intensity on opposed phased imaging. So this makes the diagnosis of fatty lesions. But are we sure now that these fatty lesions are pseudotumoral steatosis? Because they could be as well steatotic hepatocellular adenoma. But there are some clues which enable us to distinguish between pseudotumoral steatosis and adenomas. In pseudotumoral steatosis, lesions are usually small-sized, with a similar size, and I don't know why, there is often a rim which is even more fatty at the periphery of the lesion and which is highly characteristic of pseudotumoral steatosis. And the enhancement is classically parallel to the liver, but sometimes we can see mild differences over time. So here, again, MR with appropriate sequences enable us to diagnose the fatty content, and imaging findings help us to distinguish between pseudotumoral steatosis and steatotic hepatocellular adenoma. This is another case. In this case, there was no remarkable findings on unenhanced or delayed CT. What do we see here is differences in liver attenuation between the central liver and the peripheral one on all these different slices. Okay. So my question is, what are these abnormalities seen only on hepatic arterial phase? So no remarkable findings, liver appear normal on pre-contrast and on delayed phased imaging. Are we dealing with a focal steatosis? Does it correspond to tumor infiltration? Answer B. Could it be a biliary obstruction, vascular disorders, or none of the above? You start to become tired. I see less and less people answering my questions. Don't worry. Now, in a few minutes, you will play with the Professor Manfredi. Excellent. I'm very, very happy by these answers. You do very well. Okay. Now, second question. Which vessels are abnormal? To explain such differences between the liver. Are we dealing with hepatic arterial disorders, or portal vein abnormalities, or intrahepatic portal branches, obstruction, or hepatic sinusoids, or hepatic veins? I have listed all possible vessels within the liver, and you are fortunate because there are only 5. Okay. Okay, let's have a look now. I was a bit too enthusiastic. There are still some lessons you can learn. Well, I don't know exactly what is your favorite choice. Okay. I would say that you really wonder whether it comes from the hepatic artery or the portal vein. Well, this is already good. But the right answer is, it is portal vein, okay? So why? Usually, you know that the blood-liver flow originates mostly from the portal vein. It means that only 25 or 30% of the blood flow comes from the hepatic artery. Therefore, if we look at the hepatic arterial phase, the normal liver should not enhance much. So if you see enhancement here, it means that the normal liver is the central. And we do see here increased hepatic arterial enhancement. But could it be a consequence of the portal venous flow? This is exactly what we will discuss. So first, you were very good at diagnosing vascular disorders. And you were right, because vascular disorders are rarely seen on enhanced phase. They predominate either on hepatic arterial phase on or portal venous phase, and they usually disappear on delayed phase. So we are really in the topic of vascular disorders. So briefly, most of them come from the portal vein abnormalities or outflow obstruction. How can we differentiate? In the first one, they are mostly seen on hepatic arterial phase, while the second one are mostly seen on portal venous phase. And here you have mentioned that the problem could come from the arteries. Yes, but secondarily, because as soon as portal vein is obstructed, there is an increase in the arterial inflow. And this is exactly what we have seen. In most of the time, we do see straight landmarks. This is a patient with an obstruction of the left portal branch, and we see on arterial phase imaging an increased arterial enhancement, which is the direct consequence of the venous obstruction. Okay. In the patients with outflow obstruction, the imaging findings are completely different. They appear as reticular or mosaic pattern and no real anatomical landmarks. Then, if we go back to our patient, and why is it a portal vein obstruction, and why don't we see any straight landmarks? Because this is the counter-example. This is a portal vein thrombosis of the trunk itself. What happens when the portal vein is obstructed? You know that in a few hours or in a few days, some little vessels, which are called portal cavernoma, veins, will try to take the place and the role of the portal vein. And we see usually these vessels in the porta hepatis, here, and they will develop here in the porta hepatis. But they are not sufficiently active to provide the portal blood flow everywhere in the liver. It is just good for the central part of the liver next to the portal cavernoma. So here we have a normal portal blood supply, which is provided by the portal cavernoma, and consequently, in the peripheral part of the liver, we have the increased arterial inflow. So as soon as you see usually an increased arterial inflow in the liver, 90% of the cases will be related to portal venous disorders. And indeed, in this case, you don't see any enhancement of the portal vein itself. If the patient is not treated, or if the treatment fails, because the reference treatment is the anticoagulation, then the portal cavernoma will increase in size, as we can see here in another patient with multiple vessels in the porta hepatis. And this explains the very first case we have seen together, where we do see an increase in the central segments, segment 4 and caudate, and atrophy of the peripheral ones. So don't be surprised to observe striking morphological changes in patients with chronic obstruction of the portal vein. One of the complications is also the bile duct obstruction, because if the portal cavernoma is large and may have also a pseudotumoral appearance, then it is developed around the bile duct. It may compress the bile duct and give all these little tiny strictures which are only related to the portal cavernoma. This entity is called portal cholangiopathy or portal biliopathy, and patients may suffer from that, which is again a consequence of the portal vein. So with that, we are finished with the liver, and I would like to thank you very deeply for your intense and brilliant, quasi-brilliant participation. Thank you very much.